Okay, welcome to our webinar. Today's presentation is on Air Quality and Health Index and Biomass Smoke in British Columbia. This presentation is being recorded and will be posted on the BC Lung website, and we will send an email once it becomes available. Please use the question box if you have any questions for the speaker. And I'm gonna introduce our speaker for today. I'm pleased to introduce our speaker, Dr. Sarah Henderson. Sarah is an environmental engineer and an environmental epidemiologist. As a senior scientist at the BC Centre for Disease Control, she leads a program of applied research and surveillance in support of evidence-based policy for the province. Sarah has expertise in a wide range of environmental health topics, including extreme weather, radon gas, food safety, water quality, and air pollution from multiple sources. She has been studying biomass smoke in British Columbia and around the world for almost 15 years. Turn it over to Sarah.
Okay, good morning, everybody, and thanks for joining us this morning. I apologize if the sound is not ideal. My headset is not working, so I'm just talking into my microphone on my laptop. Hopefully the sound will be clear enough for you. I can hear a little bit of feedback on the line, so if everybody else could mute their microphones, that would be great. So I'm going to talk to you about some work that we've done at the BC Centre for Disease Control. This was between myself, Angela Yao, who's been working here for quite a while, and Jeff Treo, who was an MPH student doing his practicum with us over the past summer. And this is related to making changes to how the Air Quality and Health Index works in British Columbia, primarily due to the effect of fine particulate matter from smoke. So I'm going to walk you through some background information on the Air Quality and Health Index, on the Air Quality and Health Index in BC, and on the updates that we made. And then I'm going to walk into the actual research results from evaluating different ways to use the Air Quality and Health Index in the wildfire season and in the winter season, which is dominated by residential wood smoke. So here we go. And for some reason, my slides are not advancing. There we go. So some background on the Air Quality and Health Index. This is a Canadian index that is used to communicate with the public about air quality and health risk. It goes from 1 to 10 plus, where anything in the 1 to 3 category is considered quite good air quality. In the 4 to 6 category is considered moderate air quality. 7 to 10 is considered poor air quality, and 10 plus is considered very poor air quality. The index is created using the 3-hour running averages of 3 different pollutants that are known to affect human health. The first pollutant is nitrogen oxide, and I want you to note the size of the coefficient for this pollutant in the equation. So the equation for the AQHI is shown in red. There's a lot of math going on there, but the important thing to understand is NO2 is 0.00871 in that equation. The next pollutant is ozone, which is 0.00537, and the third pollutant is fine particulate matter, or PM2.5, and that's 0.00487. So of these 3 coefficients, the PM2.5 component of the index has the smallest coefficient, and it's only about half of what the coefficient is for nitrogen dioxide. And this is sort of the fundamental concern around the AQHI in British Columbia. So when this index was created and these coefficients were generated in a very data-based way, the data came from 12 Canadian cities, and they're listed here below, a couple on the East Coast, most of them in the in the Ontario and Quebec region, and Winnipeg as well. So that's sort of central Canadian corridor, and then Edmonton, Calgary, and Vancouver. But what the index doesn't necessarily reflect is the kinds of pollution that we see more out west than in the east. And one of those types of pollutants is wildfire smoke. Another one is smoke from open burning of forestry slash or land development clearing. And the third is residential wood smoke, especially in the kind of valley topography that we have in BC. So here's the AQHI website for British Columbia. This is posted on the BC Ministry of Environment website. You can go and you can look at the Air Quality and Health Index for any of the many stations in the province. At the top, you can see the scale, and on the right-hand side, you can actually go and click on a map, and it will show you in real time what the values are across the province. So it's good to know that you have this data readily available to you at any time. There's also an Air Quality and Health Index smartphone app that runs on either iOS for iPhones or on Android for phones that use another operating system. And that's a really nice app for just going and finding out what the air quality is. You can set the app to alert you to degrading air quality in your area if you want to. And this is the tool that we use to communicate about air quality with the public in Canada. Again, here's these 4 different categories of AQHI. You can see the low, moderate, high, and very high risk, and the values of the AQHI that fall into each of those categories. And then there's, for each category, there is health messaging for the at-risk population and the general population. Generally speaking, the at-risk population is defined as people who have some sort of pre-existing chronic health condition, such as asthma, heart disease, diabetes, young children, or older people whose lung function may not be as good as it once was. So for people who fall into the at-risk category, it is recommended that they follow the advice on the left-hand side, and for everybody else, it's recommended that they follow the advice on the right-hand side. You can see there's not very much difference between them. The messaging's just a little bit more stringent for those people who may be at higher risk. So now we get into the AQHI in the context of British Columbia. As I said earlier, the AQHI was developed in cities and in large cities, and most of those cities were in the more eastern parts of Canada, where they don't necessarily experience the kinds of fine particulate matter exposures and sources that we see in British Columbia. So again, that's wildfire smoke in summer, and we've certainly seen a lot of that over the past couple of summers. Open burning of slash in the shoulder seasons, either from forestry or from land clearing, and then residential wood burning in winter. Although residential wood burning does take place Canada-wide, again, the topography of British Columbia means that we have these valleys where smoke can kind of pool and accumulate, especially over wintertime nights. So these are important sources of air pollution in BC, and they are almost entirely dominated by PM2.5. If you remember back to the first slides, the AQHI is a 3-pollutant model that includes NO2, ozone, and PM2.5. But in conditions where these sources are really important, NO2 exposures may be totally normal and ozone exposures may be totally normal. And that PM2.5 component had the smallest of the coefficients in the equation. So what we have seen is that the PM2.5 is not necessarily enough to drive the AQHI into those higher categories, even when it's perceived that the air quality is not good. In addition to that, We know that PM2.5 from these sources does have health effects. There was a large study on residential wood smoke and myocardial infarction or heart attacks in British Columbia that included data from Prince George, Kamloops, and Courtenay, all of which are affected by residential wood smoke, and found that the incidence of heart attacks was quite a lot higher on really smoky days where we know that wood smoke was driving the air pollution under those conditions. We also know from several years of study that there's a lot of association between wildfire smoke and both respiratory and cardiovascular outcomes across the province. So we know that these sources are affecting health, and we want to be able to communicate with the public about those health effects, but there's concern that the 3 pollutant AQHI is not indicative of those risks. And that concern has been voiced in many different ways from different people across the province. This is just a snippet of the types of comments generally that my colleagues at the BC Ministry of Environment get. But you can see there's a lot of concern and a lot of anger and frustration amongst these comments. So, for example, the last one reads, "My question is, how do you dare lie to people on your website about the current air conditions? This is truly a very important issue which will reflect on our health in years to come. If you believe the air quality is only 4 in Kelowna right now, then I have a question. Why are you getting such a big paycheck from the government?" So, people feel that the AQHI or the 3 pollutant AQHI is not capturing their actual experience of the air quality. And not only do they lose trust in the AQHI, which is our tool for communicating about air quality, they lose trust in the people who are developing and sending out that messaging. So it's not a good situation. We really want people to have that tool reflect what they're experiencing and what they believe the risk is to their health. So based on these types of comments and concerns, we started a pilot project in November of 2016, and we called this the Trump and Hold AQHI+. This was actually before the elections occurred, but we're stuck with the Trump and Hold title. What we did was look at the relationship between the 1-hour PM2.5 concentrations and the 24-hour average PM2.5 concentrations across the province. And we looked at the 24-hour average concentrations because the province has an objective value for that averaging period. And overall, what we want to see is that all communities across BC have a 24-hour average less than 25 micrograms per meter cubed at most of the time. And we found that when there was a 1-hour average of 60 micrograms per meter cubed, it was highly predictive of a day where the 24-hour average would eventually end up being more than that 25 microgram per meter cubed threshold. So rather than waiting for the 24 hours to pass, we bumped the AQHI up to 7 as soon as that 60 micrograms per meter cubed threshold was observed. The next hour, we checked whether or not the PM2.5 values were still high, because it could be just, somebody happened to light up a cigarette right beside the station and stand there and smoke for a while and then they left. So we wanted to make sure that 1-hour average was reflective of what was going to happen for the next few hours. And if they were high, we held the AQHI at 7 for the next 6 hours. This was intended to help capture conditions where the air quality was degraded by PM2.5. I believe the public was happy that we had done something to address concerns about the 3 pollutant AQHI, but they were not happy with the way this actually played out, and I will show you why. This is how the data ended up looking. So you can see this is a wildfire situation here, and this is for Vernon. What we have is some low AQHI values. The PM2.5 hits 60 micrograms per meter cube. This thing shoots up to 7, stays at 7, creating a little table there, and then falls back down again, and then is variable for a while, and then it shoots back up to 7, and then falls back down again. And this isn't really a very realistic picture of what's probably happening with the air quality. So even though we were indicating that air quality was poor at those times when it was poor, this just didn't look realistic and didn't feel right to the people who were using it. So at this stage, we sort of took a step back and decided to take a more data-driven approach to this problem. And what we did was look at different ways that we could adapt the AQHI to the British Columbia context. We looked at 4 different possible amendments, and each of those amendments we called an AQHI-Plus. So one of the amendments was the Trump and Hold AQHI-Plus that was already in operation. The second amendment was a 1 hour only PM2.5 only AQHI-Plus. So instead of looking at all 3 pollutants, we're only going to look at the PM2.5 concentration in that 1 hour. And if the PM2.5 concentration indicates that a higher AQHI value should be shown, the 3 pollutant AQHI is overridden by the 1 hour PM2.5 only AQHI-Plus. And the equation for this, I'm going to talk about a little bit more in the coming slides, but basically we are taking the concentration of PM2.5 in the hour, dividing it by 10, and rounding up to the nearest integer. And then we also looked at 2 different reformulations of the 3 pollutant AQHI model. So instead of just sort of overriding the 3 pollutant AQHI, we adapt it and we increase the coefficient for the PM2.5 component. So here you can see in the 1.4 times PM2.5, we've multiplied that coefficient by 1.4. And in the 2 times PM2.5, we've multiplied it by 2. And I'll tell you in a moment where that 1.4 and where that 2 came from. So this is the 1 hour only or the 1 hour PM2.5 only AQHI-Plus, and you can see how it plays out at the bottom of this plot. We have concentrations of PM2.5 up to 150 micrograms per meter cubed, and on the y-axis we have the AQHI, and you can see that any concentration over 30 micrograms per meter cube bumps us up into the moderate air quality category, and any concentration over 60 micrograms per meter cube bumps us up again into the poor air quality category, and then over 100 we go into the very poor air quality category. And this was basically a linear extrapolation between the 30 value and the 60 value. And here is why. We have found, based on conversations with people who use the AQHI, that there was concern, particularly around biomass smoke, that they could smell smoke and they could know that there was smoke in the atmosphere because of that smell, but then they would look to the AQHI and it would still say that the air quality was good, even though they were smelling that smoke. And again, there's this question of the fundamental disconnect between what people are actually experiencing and what they believe to be a risk to their health, and to what the AQHI was telling them about the air quality and their health risk. So we did quite a bit of research and found through assessment of multiple papers that the threshold for odor perception of softwood smoke, which is the predominant type of timber that we have in British Columbia, was around 30 micrograms per meter cubed. So we believe that people are going to start smelling smoke at about the threshold of 30 micrograms per meter cubed, and that's when we wanted to bump the AQHI value into the moderate risk category. In terms of the 60 micrograms per meter cubed category, we kept the same reasoning that we had used for the Trump and Hold AQHI+, which was that a 1 hour concentration of 60 micrograms per meter cubed was a pretty good indicator that we were going to reach a 24-hour concentration of 25 micrograms per meter cubed, which is the air quality objective for the province and generally the concentration at which an air quality advisory would be considered by the Ministry of Environment. Now we get into those increases in the coefficient in the 3-pollutant AQHI model. And this work was done by Dave Steve, where he pulled together a bunch of studies that had looked at the relationship between PM2.5 during wildfire smoke and mortality during wildfire smoke periods. So the AQHI was developed on the relationship between daily air quality and mortality in a bunch of cities. This time, the question is related to air quality and mortality during smoky periods. And in summarizing this evidence, what Dave found was that the effect of a 10 microgram per meter cubed increase of PM2.5 due to wildfire smoke was 1.015. You can see that down in the bottom right-hand corner. And he knew from the original work on the AQHI that the effect of a 10 microgram per meter cubed increase in PM2.5 in the cities that went into the AQHI was 1.011, and that's in red down there on the right-hand corner. If we divide that 1.5, so a 1.5% increase in mortality during wildfire smoke by the 1.1 or a 1.1% increase in mortality during normal periods in a city, the resulting value is 1.36. That's down in the bottom left-hand corner, and that's where the 1.4 came from. Similarly, in review of these studies, Dave also noticed that there were a few studies that were reporting a risk that was almost double or in the range of double of what was seen in the original AQHI study. And in that we used as kind of a worst case scenario. Maybe PM2.5 on smoky days has 2 times more risk than PM2.5 on regular days. So that's where the 2 came from in the second one of these. So now we have our 4 AQHI plus amendments, and to make a good decision, what we wanted to do was test those values against different health outcomes within the population that we expect to be sensitive, in this case, to wildfire smoke. So we did this assessment in 2 different pieces. First, we looked at wildfire smoke during summer periods, and then we looked at other forms of biomass smoke during the winter, this fall and winter period. So I'm going to talk about the wildfire smoke assessment first, and then the what we'll call the residential wood smoke assessment second. The 5 health outcomes that we looked at on a daily basis were number of deaths, number of cardiovascular outpatient physician visits, number of respiratory physician visits, number of asthma-specific physician visits because we know that people with asthma are quite sensitive to biomass smoke. And then number of salbutamol dispensations. Salbutamol is Ventolin, or those blue puffers that people who have asthma or other obstructive respiratory diseases use when they're having difficulty breathing. We covered all of the summers from 2010 through 2017, and those included 4 severe wildfire seasons: 2010, 2014, 2015, and 2017. Obviously, 2017 was more severe than any of the prior 3. We also looked at 32 different health units across the province. 23 of those were outside of Greater Vancouver, so outside of sort of a large urban environment, and the rest of them were in Greater Vancouver. So this is just a plot to show you a little bit more about this concern around the AQHI and PM2.5 in the 3 pollutant model. This is a time series of PM2.5, NO2, and O3 concentrations in Prince George from the summer of 2014 when it was quite smoky. And it just shows us a few days in August. The black lines are the concentrations of the pollutants, and the blue bars underneath, which are the same for each of the 3 plots, are the AQHI value in that hour. And what I really want you to notice here is we have some reasonably high AQHI values. So we're sort of at 4 through August 1st and 3rd, and then we bump up to around 6 and then 7. We don't get much higher than that. But when we look at the sort of the middle of August 3rd, we have this peak PM2.5 concentration. And that peak is 80 micrograms per meter cubed, which is, about 8 times higher than the baseline, which is 10 micrograms per meter cubed. And that's the dashed line that you see here. So this is quite a large increase over kind of what is normal during a period like this. And even during that large increase, we do see the AQHI has been bumped into the moderate category, but it's not showing up in the high category, even though that's quite a lot of smoke exposure, especially compared with what people are used to. And then when we look at the bottom 2 plots, we see that the NO2, most of the time it's sort of just bouncing around the baseline. A little bit in the beginning here, we have some higher NO2 concentrations. And then the O3, or the ozone, same deal. And in the bottom of the plot here around August 5th, we have one period where the ozone's maybe 3 times higher than it normally is, but it's never 8 times higher. So even though we have this high PM2.5 episode in Prince George, the only time the AQHI gets bumped over 6 is during this period when there's also high ozone. But the increase in the ozone over the baseline is much lower compared with the increase of the PM2.5 over the baseline. This is just showing how, when we apply these different AQHI plus amendments, how the AQHI values shift. So on the left-hand side, you have all of the AQHI values in this 2010 to 2017 period and how they fell out for the 3 pollutant AQHI. And then on the right, it shows you how those values are redistributed for each of the possible amendments. For the Trump and Hold amendment, we can see that there's no redistribution above that hold value of 7, and a little bit of redistribution underneath. For the 1 hour PM2.5 only, you can see that in the 10 plus category, we've sort of doubled the number of values that would be in there. And then there's kind of a shifting all the way along. But even For the 4 and below categories, even for the 5 and below categories, there's not much change there. And then we see bigger changes in the 2 restructurings of the 3 pollutant AQHI-Plus amendments. So overall, we can see that the biggest shift occurs for the AQHI with 2 times the PM2.5. The smallest shift happens for the Trump and hold, and there's moderate shifts in between. The greatest increase in any of the categories is about a 3-fold increase, and that's happening more towards the higher values of the AQHI. Here are as a map of the data that were included during the wildfire season. So all of these polygons, or these regions that are shaded in gray, were included in the analysis. The green dots show where the AQHI stations were within these regions. And then in the lower mainland area, you can see in the inset there, the ones that were shaded are the ones that we consider to be in the Metro Vancouver region. And we did analyses a little bit. We sometimes left the Metro Vancouver region out of the analyses because we know that it's less affected by wildfire smoke than some of these other regions that are more densely forested and more directly affected areas. On that note, the crosses that you see here are fires that were burning in the extreme fire periods. Those ones are colored in red, and the fires that were burning in the less extreme seasons, those ones are colored in orange. So you can see a lot of wildfire activity through, the more dry interior of the province. The statistical analyses I don't want to get into too deeply, but what we did was assess the maximum reported 1-hour AQHI or AQHI plus value in a 48-hour period, and then compared that with the counts of those 5 outcomes on each day. And we wanted to look at the 48-hour period because sometimes, especially during smoky periods, there's nighttime inversions, so concentrations of air pollutants get worse over the evening hours. And if there was a high concentration at 11 p.m. the day before somebody went to the doctor for an asthma-related physician visit, we wanted to be able to capture that overnight effect. All of the models were fitted with generalized linear mixed effects models with a random effect accounting for the health unit. They were adjusted for the daily temperatures, weekdays, holidays, and long-term trends. And then we used something called the AQHI information criterion to evaluate how well each model was fitted to the data. This is basically a measure of how much information is lost when you fit a model, and obviously we want as little information to be lost as possible, so we're looking for the smallest value of the AIC. Finally, we stratified the models by season and what we're calling rurality, where we looked at those regions within Metro Vancouver separately from those regions outside of Metro Vancouver. And these are the results for the wildfire season. So here, every time you see the darkest red color, that is the model that was best fitted to the data, or the one with the lowest AIC value. And I've tried to highlight the results for you here. So when we look at mortality and cardiovascular physician visits, and this is across all summers, so all 8 summers, including the extreme wildfire seasons and the less extreme wildfire seasons, we see that the AQHI is best fitted to mortality, the original 3 pollutant model, and the AQHI is best fitted to cardiovascular physician visits. We also see that there is a significant effect of the AQHI on both of these health outcomes. They're both elevated well above 0. When we look at the respiratory physician visits. In this case, we also see that the AQHI was best fitted to that outcome. But when we switch to looking at this asthma-specific impacts, and again, we know that people with asthma are particularly sensitive to the effects of smoke and to the effects of wildfire smoke, we see that the 1 hour PM2.5 only AQHI-Plus is better fitted to the data for both asthma-related physician visits and Ventolin dispensations. So very nice, clear picture of what's happening here. When we look at the extreme seasons only, so those really smoky seasons, 2010, 2014, 2015, and 2017, we still see that the AQHI is best fitted to mortality and cardiovascular physician visits, but now we see that the 1 hour PM2.5 only AQHI-Plus is better fitted to respiratory physician visits, and it's still best fitted to the asthma-related outcomes. So for the wildfire season, this is what we concluded. The AQHI and all of the AQHI plus amendments were associated with all of the health outcomes. So in some ways, they're all telling us, giving us information about potential health risks to the population. The AQHI was best fitted to the mortality and cardiovascular outcomes across all wildfire seasons, even including the extreme wildfire seasons. And the 1 hour PM2.5 only AQHI-Plus was best fitted to the asthma-related outcomes across all seasons and best fitted to the respiratory outcomes in extreme wildfire seasons. So we recommended that if we want the AQHI to do the best possible job of communicating about risks, health risks to the population, the 1 hour PM2.5 only AQHI plus should be used during the wildfire season to ensure that we're doing the best job possible. We also concluded that a similar review would be necessary for seasons affected by other types of wood smoke, simply because wildfire smoke is very different in terms of how it's generated and how it's distributed and how high the exposures are compared with smoke from things like open burning and residential wood burning. So just to give you a little bit of an overview here, this is a picture from August 19th, 2018. Again, we had another very severe wildfire season, and you can see this is with the AQHI plus running in all of those cases where we're in the very high value, that dark brownish red. Probably it wouldn't matter whether or not the AQHI plus was running because the concentrations were so bad that the 3 pollutant AQHI would be in that category anyway. But in cases like you're seeing in the lower mainland there, that's probably Abbotsford, that's shown in yellow. That would be an AQHI plus value. Possibly the same is true in Squamish there. So we're seeing a little bit more definition of the air quality because this was running in 2018. Now let's move on to the residential wood smoke season. Again, we used very similar methods and very similar data. So we used all of the same AQHI plus amendments, those 4 that we talked about earlier. We used all of the same health outcomes, again, mortality, cardiovascular visits, respiratory visits, asthma-specific visits, and Ventolin dispensations. We covered the same time period, but we stratified the data a little bit differently this time, where we looked at all of the 20 health units included in these analyses, and we did not include Metro Vancouver at all this time. And we stratified them by those that were more affected by residential wood smoke and those that were less affected by residential wood smoke. And I'll talk about that in a second. Here's just another similar plot. from the one that I showed you from Prince George in the summer of 2014. This is from Courtenay, which is one of the most wood smoke impacted communities in BC, from the winter of 2014. And once again, you can see that the baseline concentrations of PM2.5 in this case are a little bit higher than they were in Prince George, but we're still looking at about 15 micrograms per meter cubed. And during the peak PM2.5 concentrations, which are all kind of happening overnight when there's smoke inversions, we're seeing concentrations up to about 60 micrograms per meter cubed. So this four-fold increase over the baseline. The NO2 a little bit less increased over the baseline, and the ozone even less increased over the baseline. Important thing to note here is that the AQHI never really gets above 4. So again, even though we're seeing quite bad air quality impacts, the maximum concentration we saw in Prince George was at 80 micrograms per meter cubed. This is 60 micrograms per meter cubed. We're not really showing much change in the air quality. So this is an hourglass figure. I'll give you a little bit of information on how to interpret this, and then I'll show you how we split up the 20 health units for these analyses. On the left-hand side, you have the hours of the day starting at midnight and going to midnight, and on the bottom you have the months of the year starting in the summer and going into the summer. So you have the winter months in the middle and the fall months sort of at the edges, and then the summer months at the far edges. And what we expect to see in a smoke impacted community is exactly this pattern, and I call it an hourglass pattern. So we expect to see the highest PM2.5 concentrations overnight, partially because of those types of inversion conditions and partially because people are burning more when they're home and less when they're out during the day. And then we expect to see higher concentrations in the colder months. So this is, for me, exactly how a community that is dominated by residential wood smoke looks when you plot the data this way. In the 20 health units that we looked at, and I'm sorry that the titles are quite small, but they are Courtenay, Howe Sound, Smithers, Greater Victoria, Quesnel, Cowichan, Castlegar, Sook, Caribou, Chilcotin, Prince George, Peace River, Central Okanagan, Mission, Vernon, Nanaimo, Chilliwack, Hope, Abbotsford, Agassiz, and Kamloops. You can see in the top 10, we have that kind of hourglass shape more than we do in the bottom 10. That doesn't mean that the bottom 10 communities aren't affected by residential wood smoke. I live in Mission. I know that we have a lot of wood smoke. It just means that it's not the thing necessarily that's dominating the PM2.5 concentrations or the air quality, whereas at the top we have these communities where residential wood smoke is sort of the dominant air quality problem. And so this is how we stratified the data. The top 10 communities were the more wood smoke impacted, and the bottom 10 were the less wood smoke impacted. This is how it shows on the map. You can see the regions in darker gray were the more impacted communities, some on the island, some on the interior, and these ones in the middle gray were the less wood smoke impacted communities, and then the ones in the light gray were not included. So 20 of the health units were included compared with 32 in the summertime analyses. So another similar plot just showing the shift of how AQHI concentrations were distributed among the 4 different AQHI-Plus amendments. Here you can see a couple of gray bars because there were no values in those categories in the original data. Again, we're seeing a similar kind of larger shift towards the AQHI with 2 times the PM2.5 coefficient. That's where the biggest shift is. And here are the results from basically the same analyses. Everything in red is the best fitted model, and then blue is the least best fitted model. We've got a little bit of rainbow of colors going on here. And the first thing you might note is that the situation is not nearly as clear as it was for the wildfire season. I can't just draw easy boxes around the best fitted approach here because we've got a bit of a rainbow. Among the rainbow, the thing that is most important to me, and I believe should be most important to you, is that the more impacted communities, the triangles, almost always have higher effects than the less smoke impacted communities, which are the circles. And that is very clearly evident for the salbutamol dispensations, where you can see all of the triangles are up above 1, where all of the circles are almost under 1. That's also true for the asthma-related physician visits, a little less true for cardiovascular outcomes, and a little less true for the respiratory outcomes. We also note that there's no clear association between any of these AQHIs and all-cause mortality. So one of the big differences between the summertime analyses and the wintertime analyses is related to temperature. And here we're in a situation where temperature has a very clear and well-known effect on most of the outcomes that we're looking at. So it's a little bit more difficult to disentangle the effects of temperature from the effects of PM2.5. In this particular plot, I'm showing you estimates that have been controlled for temperatures over the past 3 weeks. If we look at a plot where there's no temperature control, I'm just going to toggle back and forth between these a bit so you can see the magnitude of the difference between them. Especially look at the respiratory physician visits. Oops, sorry. So here, respiratory physician visits are almost all sitting on that 0 line. Here, without the temperature control, they're all elevated. Even for mortality, we see a pretty big shift. And we see some shifts in other places too. So this question of temperature control is important. When we look at the ones that are controlled for the same day temperature compared with no temperature control, especially in the respiratory physician visits, we see this attenuation of the PM2.5 or the AQHI effect. Regardless, through all of these models, we're seeing a clear difference between the less impacted and more impacted communities with respect to those asthma-related outcomes. So just to summarize all of that rainbow with another rainbow, here's how it played out. Everything in red is the best fitted model. Blue, again, is the least best fitted model. Anything in brackets indicates that the effect of the AQHI was actually protective, which is not necessarily what we would expect. Anything not in brackets means that there was a positive association between the AQHI and the health outcome. On the top, we have the more impacted LHAs or health units, and on the bottom, we have the less impacted health units. On the bottom, you can see that there's lots of protective effects. In a lot of cases, that's due to the 21-day temperature control. On the top, you can see that the best fitted options for the AQHI-Plus were the trump and hold for mortality physician visits and respiratory physician visits. We don't have to worry too much about mortality here because there was no significant effect. And then the 1 hour PM2.5 only was the best fitted for the asthma physician visits and for the Ventolin dispensations. We've already tried the trump and hold. We know that people don't like it. The commonality between the trump and hold and the 1 hour PM2.5 only AQHI-Plus is they're both based on 1 hour PM2.5 concentrations. So here was our final conclusions from the Woodsmoke season analyses. First, the risk of mortality was not significant in any model. That is different from what we saw during the wildfire season. Second, the risk of all other outcomes were consistently greater in the more wood smoke impacted health units compared with the less impacted health units. Third, the temperature adjusted non-mortality outcomes in the less affected health units were largely less than null. We weren't seeing a big effect of the AQHI in those places. Fourth, the 1 hour PM2.5 only AQHI-Plus was best fitted to the asthma specific outcomes in the more affected LHAs. Again, that's totally consistent with what we saw in the wild smoke analyses. And third, the Trump and hold was best fitted to the cardiovascular and respiratory physician visits in the more impacted health units. Overall, we recommended that the clearest way forward was to keep the 1 hour AQHI, 1 hour PM2.5 only AQHI plus running through both the wildfire season and the residential wood smoke season, so that we're not changing models mid-season. We know that this is giving us the best possible information for those asthma-related health outcomes. And this is just a time series of the currently running AQHI Plus in Courtenay and Duncan. Again, these are two quite impacted communities with respect to residential wood smoke. So it's kind of nice because these data are from the Ministry of Environment website, and you can see if we look at Duncan, you can see that the MOE website doesn't actually integer the values. So we have this continuous flow of AQHI values up until about November the 5th. And then we can see that we're going straight to integer values. And anytime you see these jumping between integer values, you know that the 1 hour PM2.5 only AQHI Plus has overridden the 3 pollutant AQHI model. So you can see basically from November the 6th through to yesterday, the air quality information for Duncan was being dominated by that AQHI Plus, and a very similar sort of pattern for Courtenay. So we know that this thing is working and providing information, and you can also see that these higher AQHI values are happening pretty much overnight every night in these smoke impacted communities. So finally, this has been running since May the 1st of 2018. Everything we've heard so far indicates that people were pretty satisfied with the way it operated through the wildfire season, with the exception of some remaining confusion about the 10+ values and what those actually mean. We can see from the residential wood smoke season so far that this AQHI Plus is clearly indicating the impacts in smoke affected communities. And there will be a provincial decision forthcoming about whether or not this is going to be a permanent change based on the pilot program that will hopefully run at least through till May of 2019. So we'll get a year of data before we make any permanent decisions about this. And that's all I have for you. And I've been talking for a really long time, so I'm very happy to take any questions. I hope people are actually still there. And I don't know how questions work, so maybe Men asks them.
Right. So there's one question, it says here, okay, I cannot read it very well. Did you situate monitors that collect data right in the neighborhoods where burning was happening? Some neighborhoods can be far away from the ministry instruments that collects data.
Yeah, so we didn't for this study. I mean, we're looking at what to report in terms of the AQHI, and the AQHI is only calculated at regulatory monitoring stations that have instruments for all 3 of the contributing pollutants. We certainly know from other work and a lot of mobile monitoring we've done in the province over the past couple of years that that wood smoke is a very localized consideration, and that you can live in one area and the AQHI being reported at your nearest monitoring station can be very different from what you're experiencing. Unfortunately, the AQHI is not really suited to those sorts of situations.
Okay, there is another question here, Sarah. Actually, there's another one. Is it possible to look at the last conclusion slide? So does it mean that 1 hour PM2.5 AQHI-Plus, the most feasible tool for communication to public for both wildfire and wood smoke?
Sorry, I'm not quite sure. Is it the most feasible?
Yes, tool for communication to public for both wildfire and wood smoke.
Well, yeah, so, when we're looking at air quality that's dominated by either wildfire smoke or residential wood smoke, the pollutant of most concern is the PM2.5. So it makes sense that is the pollutant that we would use to override the 3 pollutant AQHI where it is being calculated. However, if you live in a community that doesn't have an AQHI station, but does have a PM2.5 station, simply looking at the PM2.5 data can provide good information about the potential health risk. So if we're looking at adapting the AQHI to air quality situations dominated by PM2.5, I do believe that the PM2.5 is the best way to adapt the AQHI, but the PM2.5 in and of itself holds lots of information in the absence of a 3 pollutant AQHI.
Okay, another question here, Sarah, for you is what are other likely causes of higher PM2.5 values in the winter months?
What are other likely causes of high?
An example is Kamloops. So what?
So the thing about winter months is the atmospheric conditions. So PM2.5 from any source can be not dispersed well if the atmospheric conditions don't favor that. So we can definitely get inversions where all sources of PM2.5 are trapped close to the surface layer, regardless of where they come from.
Okay. Another question is that, can you please explain why AQHI is not best suited for BC again? Because there are less monitoring cities in the West than in the East. How do you compare the application of 1 hour? Okay, sorry. Can I repeat that question? Can you please explain why AQHI is not best suited for BC? And okay, yeah.
Let's start with that. So again, the AQHI was developed with information about 3 pollutants, NO2, ozone, and PM2.5 in 12 cities across Canada. 3 of those cities were in Western Canada, the rest were in Eastern Canada, and all of those data came from urban environments where traffic is one of the most important sources of traffic is highly dominated by NO2 and not PM2.5. So this tool was developed based on data from places where PM2.5 was certainly a part of the air quality mixture, the air pollutant mixture, but not the dominating part of the air pollutant mixture. In BC, we often have conditions where PM2.5 is the dominant pollutant in our air quality mixture because we have sources of biomass burning.
Okay, a follow-up question is that how do you compare the application of 1 hour PM2.5 AQHI model with AQHI equals to 0.047 PM2.5 PM2.5 as suggested by Public Health of Ontario in 2013?
I'm sorry, I have no clue what that question means.
Okay, how do you compare the application of 1 hour PM2.5 AQHI model with AQHI equals to 0.047 PM2.5 as suggested by Public Health Ontario in 2013?
Okay, I'm going to give what I believe is my interpretation to this question. Public Health Ontario has suggested that the AQHI coefficient be increased to 0.047 in the 3 pollutant model. That's a very large increase for the PM2.5 coefficient. And you're asking how we compare the 1 hour PM2.5 only with that coefficient chosen by Public Health Ontario. I don't know. We'd have to run all of these analyses again with the Ontario definition of the PM2.5 in the AQHI.
Okay, another question. Based on further provincial decisions, will PM2.5 stations be distributed throughout those areas with AQHI stations?
There's no such thing as an AQHI station without a PM2.5 station. So the PM2.5 is necessary to calculate the AQHI. So we have about 80 PM2.5 stations across the province, but I think only about 35 AQHI stations where all 3 pollutants are being measured. Are we going to see an increase in the number of AQHI stations across the province? I'm guessing that slowly over time, yes, we will, but I'm not exactly sure what the ministry's plans are.
Okay, another last question. Are there any general conclusions and guidelines for when and how to change the AQHI equation that should be used?
No, I think, based on conversation with colleagues at Health Canada, there's ongoing work to make sure that the AQHI is a useful tool Canada-wide, and there will be possible changes to the way the AQHI is both calculated and used in future. So I think there's awareness around the fact that maybe the AQHI doesn't work for everyone in all situations, and that is being evaluated at the national level. So hopefully the work we've done here can sort of help to inform that conversation at the national level, especially for conditions that are dominated by PM2.5 from biomass smoke. But there's also other concerns to be addressed, SO2 in highly industrialized communities, all those sorts of things. So I think, the AQHI will continue to evolve to meet the needs of Canadians in years to come.
Okay, thank you very much for sending your questions. If there are some other questions in here, we may send it to Sarah if she wants to see those questions. But before we let Sarah go, we would just like to remind people to register to our air quality workshop happening at the Pinnacle Hotel in February 6, 2019. Early bird registration is ending on November the 30th, so take advantage of that. And at this point, I would like to thank Sarah for the very informative talk at this time. The recordings will be available as soon as it is available on our website tomorrow. All right, thanks,
Thanks everybody.